Non-alcoholic fatty liver disease is a very common cause of liver disease worldwide. It is when you see fat in the liver in the absence of other causes of fatty liver, like alcohol or some of the medication. It is a spectrum of different diseases that ranges from just having simple fat and not a lot of other changes to what we call non-alcoholic steatohepatitis, which is called NASH. And it's important to make these distinctions because NASH is the subtype that actually progresses to advanced liver disease, including cirrhosis and liver cancer. 3 to 5% of the US population will have NASH, the type that could potentially progress. So, but still, that number is almost twice the number of patients who have hepatitis C in this country, because that prevalence of hepatitis C is about 1.8% in the general population. NASH is about 3 to 5%. So it's a very important disease, and it is probably a major cause of liver disease now, and is going to become even increasingly more important as we cure hepatitis C, and this is going to become, for sure, the number one cause of liver disease, cirrhosis, liver cancer, and liver transplantation. Well, historically, non-alcoholic fatty liver disease was considered to be a benign condition by clinicians. This is over 25 years ago. Most patients did not develop bad liver cirrhosis, and that's actually true. However, if you look at a subgroup of patients with fatty liver disease, the NASH subtype, that can progress to cirrhosis. But the lack of understanding of this complex phenotype that looks like fatty liver still has not been actually translated into an increased knowledge in our primary care side and even our endocrinologists and other subspecialists. There is increasingly more knowledge, but still, when you look at the data from the VA that was assessed, only about 39% of patients who had abnormal liver enzyme even were considered to have possibly not abnormal liver test, and only about a quarter of these patients with abnormal liver test had the potential diagnosis of non-alcoholic fatty liver disease. So there is a lack of understanding by primary care that needs to be changed, and for people to understand that this is a complex disease with a subgroup of patients with NASH, which is a substantial number, 3 to 5% of patients with US population that can have NASH and potential for progression. I think there are a number of things that we need to sort of do. One is to increase the awareness about the subtype of fatty liver that can actually progress. The more we do this, the better it's actually going to be recognized that this has to be treated or at least addressed. The more component of metabolic syndrome that you have, for example, if you have diabetes and obesity, then the risk of having the bad type of fatty liver, the NASH subtype, is even higher, that it can progress. The second thing is that we need to understand that this is going to be a disease that is going to be very heterogeneous, leading to a single phenotype of fatty liver. That has to be understood. There is also a great deal of effort to develop biomarkers, non-invasive biomarkers, either by blood testing or by very sophisticated imaging, so that you don't have to do a liver biopsy to make the diagnosis of NASH. And finally, there is a great deal of treatment protocols that are actually being developed. Currently in 2016, only vitamin E is actually recommended for patients who have NASH without actually diabetes, but nothing else. Lifestyle modification is recommended universally, but it is very difficult to actually administer that and actually get it to become successful. So there are a number of drugs that are being used and actually being tested right now. In large clinical trial, there is a FXR agonist that's being actually tested. There is actually a number of PPAR sort of agonists that are being looked at.
Can you explain PPAR?
I'll just say that PPAR agonists are going to be important in reduction of insulin resistance and sometimes even fibrosis and inflammation in patients with NASH. And there are a number of anti-fibrotic agents that actually looks at fibrosis that is going to be actually used for treatment of more advanced type of NASH. The bottom line is that what we probably will have at the end of the day will be a combination of a number of sort of drugs that are safe, effective, that can be used in long term, because that's what you have to do for this. This is another manifestation of metabolic disease, like cholesterol problems. So you don't treat for 6 months or a year. So you have to have drugs that are not only effective but safe in the long run, because you can actually then not only improve fibrosis or NASH, but hopefully you can actually improve not only patients' longevity, survival, but also their quality of life or their patient-reported outcomes.
Is the fatty liver disease itself fibrotic?
So fatty liver by itself may not be fibrotic. The NASH subtype, some of them may not have fibrosis. But when you develop fibrosis, especially if you have stage 2 fibrosis, this is out of a stage 4 staging, that is actually been shown to be independently associated with liver-related mortality. So having significant fibrosis is a bad prognostic indicator when you see that by biopsy. So fibrosis is one of the complications that happen because of having NASH, and it is a prognosticator of having bad outcome in the future. Obeticholic acid is not approved for NASH. It is being considered for treatment of primary biliary cholangitis, which is another form of liver disease. However, OCA, obeticholic acid, is being actually tested in a large clinical trial of patients with non-alcoholic fatty liver disease. So are other drugs. There are drugs like GFT505. There are drugs that are actually antifibrotic, like anti-loxol antibody that is being developed in combination with another sort of agent that is an ASK1 inhibitor. Again, this is looking not only as getting rid of fibrosis, but also helping with the inflammation. So there are a number of different sort of drugs that are being tested. Outside vitamin E, there is nothing that is actually currently available in practice that can be recommended to our patients. One of the two things that should be recognized, one is that in 2013, which I assume that it's going to be the same in 2016, NASH is the second indication for liver transplantation in the United States. This is a very important finding. The second important issue is that historically we thought that NASH cirrhosis was a risk for liver cancer. Now we are finding out that some patients with NASH without cirrhosis actually have liver cancer. I think that number in general, because you've got 25% of US population having fatty liver, is a small number that will develop liver cancer, but we need to be cognizant of these patients that have fatty liver, even without cirrhosis, that they may be at risk for having liver cancer, hepatocellular carcinoma.